So it's a great pleasure for me and an honor to introduce Stefan Rammelt. He's from Dresden, Germany, which used to be in East Germany, very old German town. He was born there and lived most of his life there. Did go to medical school in Leipzig, Germany, in one of the oldest universities in Germany. For perspective, I mean, it was founded in the early 1400s. Doesn't mean all that much right now, other than impressive numbers. He's trained under Hans Zwipp, which comes out of a very famous school of traumatologists in Germany, trained by Harald Czerny, who was kind of the father of modern traumatology in the German-speaking world. Stefan has made a name for himself publishing and talking about acute traumatic injuries to the foot, but then also in particular joint sparing and joint sacrificing reconstructive surgeries for pretty severe ankle and high foot injuries, and he'll talk about a little bit of both today. He spent the last few weeks in Utah with his family, put a lot of miles on the rental car, and I think he had a great time. And I'm very much looking forward to his talks, and pay attention, there's a lot to learn here. Thank you.
Thank you very much. I'm very honored to be here, to be invited at this famous university. So all the people here, most of them I knew personally, but all of them from the numerous papers and publications. And you have a very beautiful state, so hats off how you concentrate on work. I would be forced to go outside all the time. And so this is where I come from. It's Dresden. It's 500,000 people, so maybe comparable to Salt Lake City, but apart from that, everything else is a bit smaller. And so it's 800 years old, which is not much for Germany, but it was shaped. The shape that you see, the skyline, is from the Baroque era, and it's forbidden to build any skyscrapers in the city center just to keep it. And I will, to really get your legs stretching, I will have some slides also inside the presentation. So I'm going to talk about challenges and problems in ankle fractures. And one of the great ankle guys, Hardy Weber from St. Gallen, Switzerland, wrote a nice book about it in the 60s. And Urs Heim, one of the great AO grandfathers, said after this book, the problems have been solved. And that was also my impression. I was always, as a resident, looking forward to an acute ankle fracture when I was on call, so that was my absolute delight. But as you can see, there are problems. So most of the bad cases I will show you are from Germany. Some are from neighboring countries, no one from the United States. So all of this happens. And if there's one universal law in trauma surgery, I think it's Murphy's law. If something can go wrong, it obviously will go wrong. So there are a lot of problems. I can't touch all of them, all our controversies. I will touch some of them which I stumbled across over the last years. First of all, initial treatment. We have doctors on our rescue teams, but some of them are internists, gynecologists, and they don't touch an ankle that looks like this. But it shouldn't arrive in the hospital on a splint like this, because that's bad for the soft tissues, be it an open or a closed injury. And most of the time it's very easy. These are highly unstable fractures. It's very easy to reduce it. And with a bit of ketamine, the patient will be very pleased the very moment his foot looks straight and the pain diminishes rapidly. But also in closed injuries, there's a lot of soft tissue compromise. Especially those abduction type fractures, they will invariably have problems on the medial side, the medial malleolus, especially if there's a fracture there, the fragment will peek out through the skin or try to do it, and you will have skin necrosis inevitably if you don't reduce it quickly. And then there will be blister formation and those things. So you have to be alert about the soft tissues. There's not much soft tissues around the ankle, and the soft tissues bring you into trouble that you wouldn't expect just from the fracture. This is one example. People tried to accommodate this fracture dislocation in a plaster cast, but this doesn't work. It redislocates in the cast, and every time you want to look at the wound and to see if the fracture is ready for internal fixation, you redislocate, you cause pain to the patient, you cause trouble to the soft tissues, and this patient had an X-fix on 10 days after the injury when people noted that the cast wouldn't work, and it took more than 3 weeks finally to get internal fixation. You can see this is not a normal internal fixation for an ankle fracture, so somehow then people had to compromise, and maybe reduction is not perfect, but it was the only thing that could be done in this patient, and this could have been easily avoided. So this is the classical abduction type dislocation, and this is what you can do just in the ER, and ideally on the scene of accident. And because here again there was a protruding skin, it was very easy to reduce this. And then if you don't do the surgery on the night of injury, which is okay, put an X-fix on, don't try to keep this in a cast. And then you do your internal fixation once everything is ready. Then you can do your plate and your lateral approach. And you can see that all the landmarks are fine, and I will go over that in detail later. So how about classification? Is it all that easy? I don't think so. The classical one again is the Dany-Weber classification. So Weber changed it from by a guy in Belgium, and it's a very easy one. That's the one I learned in medical school, and the problem is it only covers the fibular fracture. It doesn't pay attention to the medical structures, and the main problem, the main question remains unanswered. How about the syndesmosis? Is it stable? Is it unstable? You need to fix it or you don't. There have been several augmentations to this, but then it gets cumbersome. So with the AO-A2A classification, you have 27 groups, and surgeons hardly appear on a classification with 3 groups. So how should they agree on 27 groups? That's almost impossible. So it's still a good guideline, but you have to keep in mind the medial side. You have to keep in mind the syndesmosis. So you need a classification that covers bony and ligamentous injury. And to a certain extent, the Lauge Hansen classification, he was a guy from Denmark, does it. But also it has some problems. It says that the position of the foot at the time of impact, it's either pronated or supinated, and the pronation, the talus, the bigger part of the talus, goes into the ankle mortise, and so these are prone to more unstable injuries, including syndesmotic injuries, which doesn't mean that supination type injuries are always easy. And I will have examples for that. And then the second word is the force that comes onto the foot when it's either fixed or the leg is fixed and the foot is twisted away. But Lauge Hansen, he went into the basement of his hospital, he took cadaver ankles and he smashed them by hand, manually. So it's hard to redo this experiments. Some famous people did it, and they didn't get the same results. So it's not very nicely reproducible on cadavers. And now that we have CT and MRI, and we can look at all the bony and ligamentous injuries of the ankle, we see that in many fractures, the pattern that's predicted by the Lauge Hansen classification is not there. So to me, it's a very interesting classification because it forces you to think about the nature of the injury, and it forces you to think about bony and ligamentous injuries all around the ankle. But still, you have to address every component of the injury and just don't rely on this classification. So far, I believe it's the best that we have, and it's far less popular in Germany than the United States, where I think it's the most widely used. In Germany, still, we hang on to the Weber classification. How about imaging? This is one of my favorite questions always to the residents. What is this line? And I get a lot of different answers. Of course, you all know this is the anterior tubercle of the tibia, or according to old French surgeon, the tubercule de Chaput, as we call it. I think you say chaput, yeah? So this is the anterior part of the fibula, and this is the tibia, and this is the lateral margin of the fibula. So what you have here is the tibio-fibular overlap. And as you turn the ankle, the overlap changes. So you need a mortised view with 20 degrees of internal rotation to really have a reliable number. And then this is the deepest part of the incisura, which is most of the time close to the posterior border of the tibia, and the room in between, that's also termed by Chaput the ligne claire, so it's the clear space between the tibia and the fibula. That is the radiologic measure of the syndesmosis. And this stays more or less the same, no matter how you turn the ankle. But if the syndesmosis is ruptured, this gets wider and the overlap gets smaller. And of course you have the medial clear space, which opens up after a fracture or a syndesmotic injury when the talus follows the fibula to the lateral side. So this gets wider. It shouldn't be wider than the upper rim here. And then we have some nice additional measurements, which is the Weber circle. I think in America it's the dime sign. And we call it Weber's nose, and some call it the Menard-Shenton line of the ankle. It's a term from hip surgery. So these are the things we will see over and over again, and we can do a lot with that. And these are our tools for assessing reductions in the OR when we have 2D fluoroscopy, what most of us have. And if you're not sure, if you have a non-displaced or minimally displaced fracture, you don't see the ligamentous injuries on the other side. You don't see the syndesmosis, you don't see the medial space open. You don't know if it's a SE4 or SER2 fracture. Then there's a lot of ways to find out. Handheld stress radiographs with adequate analgesia, of course, are very good because you can have a feeling if there's instability or not. And if the medial space opens up, this is an unstable injury and probably needs some surgery. If it's stable, it doesn't open up. Only pain or a blister or ecchymosis over the medial side is not sensitive, as found out from this famous surgeon in New York. And if you have the leg just hanging over to the lateral side, so the so-called gravity stress test, this is equivalent. Very interesting idea. This is not a son of Weber, but it's Martin Weber. He's also working in Switzerland. He found out that if you do standing radiographs at the time of injury, this is also a very good measure of stability versus instability. And you get less positive results than with a gravity stress test or with external rotation test because there is some stability reserved just from the anatomic ankle mortise. This has been found out before in cadaver studies and has been reappreciated in those studies. And there are some studies out, I think also from New York, that show that not all of the positive imaging fractures that go up, open up immediately, really need surgery. So maybe a standing radiograph, which is the physiological force that our ankle has, is a bit more relevant. And we get more and more generous using CT before embarking on surgery, because sometimes you see patterns that you just did not predict. So this looks like a posterior fragment, an isolated posterior fragment. And unless proven otherwise, these things do not exist. Most of they are those injuries, but they are very, very rare. This would be the first stage of a pronation injury. But most of the time, you have at least ligamentous injury to the deltoid or to the syndesmosis, and you shouldn't overlook a Maisonneuve type injury with a high fibular fracture. So again, this is the problem we have. So do a CT scan, and then you might be astonished at what else you find. You see an atypical fibular fracture that probably for itself doesn't need fixation, and you see tubercule de chapeau. So the anterior part is ripped off. So the posterior and the anterior syndesmosis are avulsed with a piece of bone. So you better put it back. And then this patient just needs some minimal incisions and will do fine. So what are the indications for operative treatment? I think so these are our indications derived from the literature, and there's a bit of controversy, but I don't think too much. So the 2 millimeter rule obviously applies. If there's dislocation, you should do it, no matter if it's deemed stable or unstable, or if just the fibula is fractured or more. The rotation is not so easy. Dave Torderson did a nice study on cadaver ankles, and he found out that the pressure changes significantly just at 5 degrees of rotation. So now who of you can judge 5 degrees of rotation intraoperatively? That's very challenging. There's a study from Rostock, from the group of Thomas Mittelmeier. They looked at patients with malreduced ankles, and they found out that if it's more than 15 degrees, internal or external rotation, then people really get more trouble, more pain, worse results. So the truth is probably in the middle. So maybe if you fix a fibula that is twisted more than 10 degrees, you're on a safe zone. Bimanual, trimanual fractures, of course, have to be treated operatively. And please consider not only bony, consider also the ligamentous injuries, including syndesmotic injuries, of course. And then we see an increasing number of fractures that are somehow transitional fractures to pilon fractures, because we have impaction of the lateral tibial clavicle or of the posterior tibial clavicle. And those should be fixed, of course, too. So this is the fracture that you most frequently see, especially in young people and sportive people from Utah that fall off the rocks or off their bicycles. And then the force goes all around the ankle, so the term external rotation really describes the injury. And all components must be addressed. So this is the residence delight, a spiral fracture that nicely can be put back together with a compression screw. Still there is a bit of gravel here, that posterior margin, but this is outside the joint, and compression screw, fibular fixation, and then everything is stable, so as long as there's no bony injury to the medial side. Even if it looks like this, then you see, of course, that there is some avulsion of the posterior syndesmosis. There's a clear widening of the medial space, but the lean clear, the syndesmotic clear space is still okay. And if you look close enough, there is an avulsion at the anterior part of the fibula. Again, this is the syndesmosis, which is avulsed with a piece of bone. It's called the Wagstaff fragment. All those names come from the 18th century, most of them. So what to do? You fix the fibula and you fix the bony avulsion of the syndesmosis, and then everything gets stable again. But even in those so-called easy supination, external rotation type fractures, there are some problems. Here some guy tried to contour the plate according to the shape of the fibula, but he did too much. And too much is never good, and so the fibula is invalid. And there is another Wagstaff fragment that has been overlooked, so it's a bit rotationally unstable. Luckily, this was detected very early and could be redone after a couple of days. But be aware, there's technical problems even in the so-called easy fractures. And how about assessing all the injury components? This is the so-called easy, the Weber type A, the easiest you can get. But you have to look not only at the tip of the fibula, you have to look to the medial side. And you can already see it here in the radiograph, and you can see it in the CT even better. There's impaction of the tibia plafond. So probably this is a next stage, and this is a transition to a pilon fracture. And if you look intraoperatively, it's very impressive. Look at this deep bump, look at the cartilage damage. So even if you fix all this, there might be some trouble down the road. This was brought down with the bone graft just from the distal metaphysis of the tibia and fixed with a mini plate and some screws. And this is the patient 2 years later, no signs of arthritis. The screws didn't want to come out completely, but the patient at this stage has a good result. Another easy Weber A that was treated non-operatively. The medial component was not appreciated, and what you see here is you see a medial shift of the distal fibula, distal to the joint, so by definition a Weber A fracture, supination abduction fracture is better, and the vertical fracture of the medial malleolus lets the medial malleolus shift up, so the medial buttress of the talus is missing and the whole talus is shifting over. This patient was drinking a lot of alcohol, but he told me it was because of the pain. So, okay, I looked at it, and there was some reason for pain. So look at the medial edge of the talus. These are not very nice photographs because I did it, not our professional photographer. You see there's cartilage damage on the medial side, and you see the step off. That's the step off 5 millimeters in a distal fibula. So what to do? You recreate the original fractures and try to put it back. He was walking on it after 4 weeks. Luckily, the stability reserve of the ankle held in him. And so we say the children and those who drink, they have a guardian angel. And this is him 3 years later. He's still not happy. He still has some residual pain, but at least the ankle looks straight now. So how about the medial malleolus? It seems to matter. And you can fix it with whatever you have at hand. You can do a wire cerclage, you can do screws, but you shouldn't go into the posterior collicle. There's a nice anatomical study in the JVJS, and as you can see here, these are the long flexors of the toes, and this is the tip post. And this was displaced during the fracture. The wire from the wire cerclage went in between those tendons, and so this was chronically dislocated in front of the wire. The wire was preventing it from coming back. So this could be easily fixed with taking out the wire and reefing the flexor retinacle, but this can be really avoided. So stay in the anterior tubercle, or at least in the center of the medial malleolus. Don't go with protruding materials into the posterior tubercle. And if you go there, then look for the tendons, retract them, and then sink the materials in. Does the medial malleolus matter at all? I think it does. We know that there's no need of fixing a deltoid ligament if you have a stable fixation of the distal fibula. And we know that isolated medial malleolar fractures need not be fixed. Another study from the United States, from Tampa. But unless proven otherwise, there is no such thing as an isolated medial malleolar fracture. 90% of them will have some syndesmotic injury, will have some high fibular fracture. So please exclude this before speaking about an isolated medial fracture. If it really is, then it's a pronation injury, stage 1. It's stable, and if it's not displaced, of course, you can treat it non-operatively, and you can treat it with a simple splint. You don't even need a cast for that because it's stable. And interestingly, the group from Norway, we had one fellow from Norway who was working there. They did another study, said if you don't need to fix the deltoid ligament, maybe you don't need to fix the medial malleolus after you have a nice fixation of the distal fibula in bimalleolar and trimalleolar fractures. And they published 2-year results, and they saw, well, the results were not dramatically different at 2 years, but they saw more non-unions. And so they say, well, you can do it, but it gives you a bit of uncertainty. Better fix it, and then it will heal. And here is a case of a non-union of a medial malleolar fracture. Again, this looks like a supination type of injury, almost vertical fracture. It didn't heal for a long time in a young lady. For me, young, maybe not for all of you, but in the middle of her working life. And so she was very painful with that condition. Finally, in the 3rd attempt, the medial malleolus healed, but it healed in that bad position. There was still that gap at some of the joint, and you see how the talus follows the medial malleolus. So I think it really matters. Maybe the fibula has also, at least the length is okay, at least some rotational problem, the distal part. I didn't want to tackle that. So she was going into varus. You see the peekaboo heel here. And these are the CT scans. So you see the medial is not only going medial, it's also shortened, so the typical deformity. And the supination fracture, and here you see the large gap. So what she needed was a closing wedge, osteotomy, and the shifting down of the medial malleolus. This is my favorite clamp for most of the fractures. It's an overriding clamp that doesn't intervene with the soft tissues. I don't get any money from that, but you see it in many slides. And this is the fixation. This is the patient 1 year later. As most of German patients, she wanted to have the hardware out, although the function was nice. But I can understand an interlocking plate over the medial malleolus protrudes somehow. This is the correction. The fibula, this seems to be enough, as I didn't want to do anything about the fibula. It was nicely inside the ankle mortised. And I took the hardware out, and this is her function after that. So the medial malleolus matters. But now about syndesmosis. I could talk for hours, but I won't. So the typical test is the lateral test as you see on the fluoroscopy. But the original publication of Heim says you have to put posterolaterally because it's rotational, external rotation, instability, and sometimes it's enough just to put your finger on the anterior rim of the fibula, and if it wiggles back and forth, then you know it's unstable. You have to fix it. And then you have to put the fibula back into the incisura. That's the most important thing. And there's many studies out there that this is the most predictive factor for results in ankle fracture treatment, and then it will be fine. And we regularly do, as a rule, in all of the patients where we put a syndesmotic screw in or any other fixation of the syndesmosis, we do a post-op CT scan. Because if you do this is a very humbling experience. We saw 20% of malreductions. So this puts the delight out of these fractures. You do it at night, you feel fine, and then you get a CT scan the next morning that looks horrible. Or at least you have some malrotation, some displacement. So we were laughed at when we presented it I think in 2000 at the German Trauma Society. Now everybody does it. And you have to see the width of the syndesmotic space, you have to see rotation, and you have to look for the congruency. And this is one very dramatical result. The syndesmosis wasn't opened up, and I think that's a very important thing. If you don't open up, you can't see debris that is inside. You overlook small bony avulsions, and you can't see the alignment. You can't feel the alignment between the anterior rim of the tibia, the chapu, and the anterior rim of the fibula, the Wagstaff. This was obviously done. The screw might be fairly high up. The Shenton line is fine. The dime sign is fine. The syndesmotic space, well, not sure. And this is the CT scan. So it was translated anteriorly. You can't see this in fluoroscopy. You can, if you're really nice in judging the lateral fluoroscopy, you can see it. But you have to be aware of it. And if you're aware of it, better open it up. And then it doesn't happen. So this was the correction surgery, fairly easy, this time with exposure. So just do it the first place. And of course you can have 3D fluoroscopy. There's a lot of studies out. The Germans were very keen on doing this. I think Siemens and Siemens were the companies pushing this forward. Of course, if you can do it intraoperatively, you don't need a post-op CT scan, and you can do the correction right away. One problem is money. Another problem is there is a variability of the incisura. So it would be a good idea then to include the other ankle into the scan. This is still an open question because sometimes the fibula is shifted at least a bit anteriorly. If it's shifted posteriorly, it's always a mistake, but there are individually differences between individuals, not between the two ankles. A lot of studies out on this. So if you have that, you can avoid CT scan. But look at it. This was done in the middle of the night. Looks okay after fracture dislocation, but if you look at the CT scan, the tibia is shifted anteriorly and it's rotated externally, so we thought this is not good, we can do better, and in fact, you can do. and now it's back in position. If you compare to the other side, it's not exactly the same kind, and the rotational deformity is avoided. And I do it if I know there is a 5-degree or 10-degree rotation. I put just poor man's navigation. I put 2 K-wires in at 10 degrees, and in the end, most of the time, there's another problem. And once you get the fibula back in the right position, you see how the K-wires align, and then you know that you have a good reduction. Another example, it really looked nice in the fluoroscopy, but in a CT scan you see this hasn't been appreciated, probably not have been opened up. This is a small avulsion of the anterior syndesmosis, and also the medial release doesn't look so nice. So the combination of both made me try to repeat this. So I just put a K-wire in here to see if I really can fix this. This is the avulsion of the anterior syndesmosis, so the ligaments are intact, they are very strong, and so by doing this, you also have a good fixation of the syndesmosis. Just because I'm a wimp, I put a syndesmotic screw on top, and I also had a bit better reduction of the medial malleolus. Of course, if you once had screws and you can't put the screws in the same hole, so I did a wire cerclage. And these, in my mind, are pseudo-controversies. 3 cortices versus 4, stainless steel versus titanium. It just doesn't matter. The only thing that matters is wonderful, many studies from the United States, anatomic reduction of the fibula into the mortise. That's the most, in the incisura. That's the most important thing. And all the other, if you, you can do a suture button, of course, but suture button is not a reduction tool, as some people think. So a fool with a tool is still a fool. That's a rule from neurosurgery. So this is a tightrope fixation, and obviously there's some problem. You see the medial clear space, you see the fibular length is not correct, and if you do a CT scan, you see there's malreduction, there's malrotation of the fibula, it's too short, and there is one paper suggesting autocorrection of the fibula if you use a tightrope, but I wouldn't rely on that. Tightrope is a nice fixation tool. It's more dynamic, so it's more physiologic than the screw. It's also more expensive, that's why I don't use it. But if you use it, fix and reduce the fibula first and reduce it into the mortise. And so we redid it. After bringing the fibula out to length, there was still opening of the medial clear space. So in addition, we used the screw, and this is the result after correction. And a very frequent thing that we see in our early revisions, problems that have not been tackled, are syndesmotic avulsions. And the reason is, if you don't fix, it's a small fragment. It's not even a joint-bearing fragment, but it prevents the fibula from staying stable into the incisura. It shapes the incisura. So bringing back those small bony avulsions, be it anterior or posterior, they shape the incisura. And unless you haven't shaped the incisura, you can't reduce the fibula into it. And so inevitably, if there's an anterior avulsion, the fibula will go forward. If there's a posterior avulsion, it will go backwards, so it will follow the avulsed fragment because the ligaments are stronger than the bone. So what to do? You can make a mistake, but then you should correct it. Only if you don't correct it, you really made a mistake. That's what the old masters told us. And if you go to a patient and tell him, we did our best job on fluoroscopy, we did a CT scan, we see there's a tiny bit we have to redo. I haven't had a single patient that was mad at me. They said, okay, these are alert doctors, they look at their mistakes, they correct them, and we didn't have a single lawsuit after doing an early correction after 3 days. If you leave it as it is and they come back with arthritis, which they can get anyhow, then you're in trouble. So just correct it, bring the fibula back, again, clamping with refixing the tubercle, and then it's stable. So by fixing the avulsion of the syndesmosis, sometimes you avoid the need of a syndesmotic screw or tightrope or whatever you would need. This is very important. If you have a tiny avulsion of the posterior malleolus, or if you have a so-called isolated malleolar fracture, always look up the whole fibula. Sometimes there's a dislocation of the proximal tibiofibular joint as a variant. So palpate the whole lower leg and make radiographs to exclude mesonerve type injuries. And if you treat them openly. Do a small incision. The group of Dave Torderson was so bold to try both open and percutaneous, and they had malreductions in the percutaneous group, no malreductions in the open group. And it's not a big incision. It's 1 inch incision, and you can see avulsions that you can fix, and you can feel the alignment of the anterior portion, and then you won't have any more trouble. And we don't need to fix the proximal fibular fracture, but it should align. If it aligns, then the length of the fibula is fine. And sometimes you have to pull it up. This was a nice percutaneous surgery, which is very modern, but it didn't work. So this is the typical deformity, shortening, syndesmotic widening, medial tear space widening after mesonerve fracture. And then you have to go for a second surgery. This is the classical Weber technique for correcting it, but this can easily be avoided in the first place. Now we go from anterior to posterior. When to fix the posterior fragment? There's a new paper out every week, I think, on posterior malleolar fractures, so it seems to be a hot topic. I believe if there is an impaction of the plafond, you have to do it. There's that old 1/3 rule from the AO manual. This is a study from 1940, Nelson and Jenkins, and they had 8 patients in the more than 1/3 group. So this is not compatible, I think Alexei agrees, with modern evidence-based surgery. But everyone copies it, and so just forget about that rule. Look at the individual fracture. I would always treat an impaction. And remember, even on a small fragment, there is the syndesmosis. So, and as you can see here, there's an intercalary fragment. This is also a transition to a pilon fracture, by definition. So you have to fix it, and my favorite thing is to do this first, because once you have a plate over the fibula, you don't see anything. So you can betray yourself, but you can't betray the CT scan that comes afterwards. And if you fix the posterior fragment, then the syndesmosis will be stable. So you beat 2 flies with 1 clap. That's the German expression for that. And there's one classification by Haraguchi, was the first one to look at the individual anatomy of those fractures. And together with Jan Bartonicek from Prague, the eldest university in Central Europe, Prague, from the 13th, you can see the involvement of the incisura is different in those fractures. So what I like to do right now is to tailor treatment to the amount of incisura involvement, because the incisura is needed for perfect reduction of the fibula, which is the single most important prognostic factor. So if you just have an avulsion that is outside the incisura, you don't need to do anything about it. As soon as the incisura gets involved, and if it's only a tiny bit, maybe if it's non-displaced, you can wait and see. But most of them are a bit displaced, and we become increasingly aggressive fixing those. And of course, those small fragments have to be fixed from behind. Then you have 2-part fractures that extend in the medial malleolus. These have to be fixed, and the large triangular fractures that go far up have to be fixed too. So I think this can guide treatment a little better. I'm not sure it's perfect, but Jan collected more than 115 CT scans and looked at all of them. So next discussion, I don't need to translate this, and you can discuss the whole night how to fix it. This is the classical technique, and there was an article in Foot and Ankle International about transfibular fixation of the fibula, which has not been formally done. Well, it has done, but unluckily only in German, so many of the scientific world cannot read it. This is the fracture, a long fracture of the distal fibula, and then, of course, you can go, and that's a trick from Weber from the 60s, It's published in his book in German, and the book is hard to get. And so we published this technique in another German paper just to show the residents how to do it. And it looks nice in the book, and it's very hard to do through the fibula. If you have a nice long fracture, then you can see this is the posterior fragment, the anterior fragment of the distal tibia. You can see the fracture, you can reduce it. Now here's the fracture line, and then you can fix it with AP screws indirectly. You don't need to come from the back for a single large fragment. And then you reduce the fibula until the dime is where it belongs. And then once you have the fibular plate, you don't see anything. So just do this first. And if you have a smaller fragment, then it's probably better because you need all the screw threads in here. And you can do this maybe with one screw, but not with two screws. And it's hard to do this indirectly. And again, you can see how the fibula follows the distal fragment. So I do these from the back. You can use screws, or you can use a plate. And then you can see how the fibula reduces just by putting the posterior tibial fragment back where it belongs. And this is a bad example. The people from the oromaxillofacial surgery called me. We have a patient with a ankle fracture. They said they've done everything except for the deltoid ligament. That has to be fixed later. And I wondered, so that sounds strange. So what happened here? AP fixation, this was inside the anterior tibial tendon. And something did not really work out. And if you look at this fragment wasn't fixed, it wasn't reduced. And so there is no incisura where you can put the fibula. So it has to be redone. It was done after a couple of days, and now incisura is back, and the fibula is where it belongs. Here we have a fracture dislocation. It was reduced in the vacuum splint at the site of accident. Very nice, a young lady. And you see there's a small avulsion, but there is an impaction, and so these impactions, if they are big enough and if there's still cartilage on it, you fix them back like you do with a tibial plafond fracture. So it's just the plateau fracture. You can put lost K-wires in or resorbable pins to keep them there, and then you flip over the posterior fragment. Because once the posterior fragment with the ligament is there, you don't see anything inside the joint. But you have direct bone-to-bone fixation, which is always more stable than just ligament fixation. Then you do the fibula, and then that's my sequence of reduction at the medium malleolus, because most of the time it spontaneously reduces quite nicely after fixation of the posterior and the lateral component of the injury. This even looks more complex injury reduced on site, and I would term this a quadrimalleolar fracture because the anterior syndesmosis, the posterior tibia is fractured, the medial malleolus and the fibula is fractured, so you have to address all of those components starting with the posterior. And you see here it was just a tiny bony intercalateral fragment that you just have to pull out. Otherwise it's just like gravel. And then everything was fixed, it was stable, and this is the post-op CT scan. So you see now there is a gap here because we couldn't fix that small fragments, but the alignment has to be fine and the incisura has to be fine. And here you see the anterior, the posterior incisura. Now this makes up for a good reduction. This is a problem we encountered more and more, especially in women. I haven't seen it yet in men. And so this is a typical example. After an abduction type of injury, patient gets into valgus and she has more and more pain. And if you, so she's very active, she runs a horse farm and increasing pain. And this is the CT scan, so this looks pretty nasty. But she's a young lady, she has a beautiful movement of the ankle. So I said to myself, okay, let's try to do something. There's not a literature out there from some famous people from Seattle. They collected some cases. They did fusion, or in 2 cases, total ankle. They don't report any results. And I'm just collecting now my results to be able to report something. So here we lengthened the fibula because it was too short too. and we did an osteotomy above the plafond, so where the fracture has not been, but where the necrosis is. And then we put bone graft into the fibula, into the tibia, and fixed it. And now, 1 year, she was better. She walks without pain. She can't run. Dorsiflexion was still a bit less. So the arthritis that's already there doesn't go away, but you can offload the lateral part of the talus and maybe buy her some time. And she wanted her heart valve. I didn't dare to take the tibial plate out because that was where the necrosis was. And so she lets do the horses most of the job, which is smart, and hopefully she will do so. She's now 4 years out, and she sends me postcards from her horse farm every year. Maybe it's sometimes will come back with arthritis. And now about the elderly patients. Again, the same old guy from China, he who does not think about the future will have trouble very, very soon. And our future is aging population, multimorbid patients, osteoporosis, diabetes. So we'll spend a few last words on that. We are somehow between a rock and a hard place. If you do a non-operative treatment, you will have a lot of trouble, higher mortality, because these patients, they are still active. They have to get out of bed. If they stay in bed for 10 weeks, then most of them will die. So this is, sometimes it's a vital decision to operate on such a patient to bring him back to his feet. On the other hand, operative treatment is fraught with complications. So this is really a hard thing. And osteoporosis is worthwhile. The ankle fractures so far are not considered osteoporotic fractures, but we see a lot of patterns that really look osteoporotic, especially the abduction type fractures in elderly women. And if there's a low energy, so this is still open to debate. Can we include ankle fractures into osteoporotic fractures? It's not only the spine, the vertebral fractures. And most of the time, at least in Germany, the fracture is the first clinical sign of osteoporosis. Then you do your measurement and you see, oh my God. So you have to treat, and it's associated with diabetes and rheumatoid arthritis. So most of these people have more than one problem. So what to do? A smart idea from New York, just add 2 K-wires and you add stability. That's what we did here in this patient. Or, a smart idea from Switzerland, poor man's surgery. Swiss are rich people, but they have smart ideas for poor ones, like we in East Germany. So just cut a slice of a pie out of the monster tubular plate, bend it around, and then you have a hook plate. Add stability. And here we have a typical fracture, misstep on a curb, elderly lady. You see how again the posterior fragment is displaced. So why not put an interlocking plate on the back, just to add some more stability, interlocking plate to the distal fibula. So, and why not put a posterior plate on the fibula? Because the soft tissues may be brittle over the lateral aspect. So once you have to fix a posterior fragment anyhow, as most of these patients have, just come from the back, put a plate on the posterior tibia, and by the same approach, just hold the peroneals aside, put a posterior plate on the fibula. You just have to be careful. The fibula, tip of the fibula should be 1 centimeter clear of the end of the plate. If it's closer to that, I think it's another study from Switzerland, you will irritate the peroneal tendons in the groove. But as long as you stay at the level of the ankle joint, it will be just fine. And it's more stable. As we know, there's a study by Art Minoli from Detroit, at least formerly, who showed that many years ago. Another, you have nicer implants, so Wade Falling constructed nicer implants for that. This is a Dutch study, did it with Tim Skeppers. So if you have really bad skin and you don't want to open up the fibula at all, you can also run into some kind of intermediary layer into it. You can use multiple syndesmotic screws. These are just 2, you can do 4 or 5. And you can do multiple interlocking plates. This is an 88-year-old female, very active, attending her garden. So X-Fix was put on, then a CT scan in the reduced position. Then you see again the problems at the posterior medius. And so this is, I shouldn't say this, but that's a distal radial plate. It's an interlocking plate on the fibula, interlocking radial plate on the medial malleolus. So this is off-label, I should warn you. And this is a plate for the fibula. And this patient came back 6 years later. She didn't want any x-rays, but she's 94, still attending her gyne. No x-rays. Treat osteoporosis, of course, once you detect it. It's our duty, because we as orthopedic surgeons will make the diagnosis if we are smart enough to do this. And the data from Germany are sobering. There are guidelines since 10 years, the bone and joint decade, it's long over, and the guidelines are followed in maybe 20-30% of cases. So these are very sobering data. Diabetes, I don't want to plunge too deep into diabetes, but that's another risk factor for wound complications, for bone healing, and sometimes the classical fixation will fail in diabetics. So this is a patient, and she had bad skin over the infection, so we couldn't do anything about this fibula. She was put in an X-fix, and then with multiple syndesmotic screws and KRAS, or a combination of the New York and Manoli technique, somehow we saved this. And this patient, this is the 1 year follow-up. You can still see the big scar over the distal fibula. Sometimes you can salvage it, sometimes you just have big trouble. This is a neuropathic patient, but otherwise healthy. He doesn't have diabetes, but some kind of neuropathy. Still, this was an adequate trauma. So what to do? So we fixed it, all parts, another quadrilateral fracture. We fixed every part of it. It was stable after fixation of the anterior and posterior syndesmosis. You know that already. This is another interlocking plate that one of my colleagues designed. They call it the Dresden plate for the fibula. Has some interlocking options. There's a lot of plates out there. Roy Sanders invented at least 3 of them, I guess. And this is the CT scan. And so we kept the external fixation for 6 weeks. We just had to polish it. And then we had the impression, okay, now the bone looks better. Then we put a cast on for another 6 weeks. And this is him now. Now he's able to walk. Now the soft tissues look better. He has chronic edema anyhow. So maybe we could save something here. Sometimes it's just not salvageable because these are different entities. So if you don't have an adequate trauma and you see such a fracture, then probably you should see if the patient has sensation on his foot, and probably it's Charcot arthropathy, and we have it in a lot of diabetic patients, and you will have the people here, and this is treated with a nail, and even that can, to a certain extent, fail. The patient was seen 3 years later. The nail somehow worked its way through. It's non-union here, it's solid here, but he walks on it in a special boot. He has foot care, so sometimes this is the best result, apart from amputation, that you can obtain in those patients. So, analyze the bony and ligamentous injury of ankle fractures. Be generous with CT scanning after gross reduction, which has to be at the scene of the accident, at the latest in the hospital when you see them. Be aware of those grossly unstable fractures. Look at the syndesmotic avulsions. They are very predictive of your reduction and of the results. Check the landmarks. Use 3D imaging if available. Do a post-op CT scan. In every case where you're not sure what you did, respect and treat comorbidities. And then you will probably find some mistakes, then correct them as soon as you detect them. Thank you very much for your attention.
It is 8 o'clock, so some people may have to leave. I'm sure there's some questions.
You can get post-op CT scan on everybody you fix in the
Where we put a syndesmotic screw in. Because we can't judge rotation, we can't judge AP shift. Not every ankle fracture.
Sure, just in the I just want to make sure.
Yeah.
Stefan, can you maybe quickly just go through the steps that you go through in the operating room to be as sure as you can be that your syndesmosis is reduced clinically as well as fluoroscopy?
So the fluoroscopic signs I showed you, and there's also a nice, in the lateral view, you can also assess AP shift of the fibula. It's reliable, it really did a lot of times, and I will always look at the other side. And the clinical ways of seeing it, one thing is really touching, put your finger on the anterior tubercle of the tibia and then go over to the fibula. If there's a step off, the fibula is not in the intersura. And if you come from posterior, you can see nicely the fracture, the outline of the fracture of that mostly triangular fragment. So you really have to see that this fracture is, so peel off the periosteum at 1 or 2 millimeters there and see that this fracture is nicely aligned. And do the lateral fluoroscopy before you fix the fibula, then you can really see it and turn it, because if you have a true lateral view, it may look nice, but you're not in the level of the fracture. If you turn it internally, then you turn into the line of the fracture, then sometimes you see that it's not perfectly reduced.
Can you speak a little bit about deltoid ligaments? I think the deltoid has a powerful effect on the stability of the ankle, and it's neglected routinely because of one study done by some Norwegian in 1995.
Yeah.
What do you think of that?
I think it's a very important ligament, and it has to heal in the proper position. So as with the syndesmosis, we don't suture the syndesmosis, but it has to be in a proper position. So if you do a nice reduction of your medial fracture, or if you do a nice reduction of your ankle fracture, then the deltoid ligament is in its proper position and it heals properly. And that's probably the reason for the results of that Norwegian study. But if the medial clear space does look weird after your fixation, then there must be a problem. And there might be, in rare occasions, that parts of the deep deltoid ligament are inside the space and you can't reduce it. Then you have to get it out, and then once you're there, you might be tempted to fix it somehow, but it's hard to fix it. The relevant portion is the deep deltoid. And the deep deltoid cannot be fixed by a direct suture. It's like the interosseous syndesmotic ligament. So you might put suture anchors in, and I try to avoid too much dissection there because the blood supply to the talus also comes from over there. But as long as it is in the perfect position, it will heal. But of course you have to look for deltoid injuries in the beginning when you see if you have a stable or unstable fracture, and you have to look in the end. And if the medial clear space is nice, if the medial malleolus is nice, then the deltoid will heal in its proper position. But you shouldn't neglect it. I totally agree.
One question about your system. So you guys have doctors on your emergency responder units, and they're doing reductions in the field rather than...
The surgeons do it, and we try to teach our anesthesiologists. Most of them we work very closely. A lot of them are anesthesiologists. They do it too. And internal medicine guys, they put a small IV drain in and bring a lot of medicine through it, and then bring the patient with a dislocated ankle to the hospital. So we try to educate them, because some of the time if you are there within minutes, you just pull on the ankle, on the foot, the patient doesn't even have pain at that stage. And then he will be very grateful that something has been done.
That's sort of the opposite of where ATLS, like what our system does. They just pack them up and bring them to us. That's an interesting experience.
Thomas?
You showed that technique for reducing the posterior mallet impaction through the fibula.
Yeah.
Should you be able to, is the distractor part of that? Are you using a distractor so that you
No,
can bring it down, or do you just...
So first of all, this was no impaction. If there's an impaction, I wouldn't use that technique.
Okay.
I use it for single large fragments, and I put a laminar spreader into the fibular fracture. So there has to be also a nice long fibular fracture. It looks beautiful in Weber's book because it's a sketch. And I waited for quite some time until I had a nice fracture that I could also bring our photographer and really show that you can see something. If there's a comminuted fibular fracture, if there's infection of the posterior tibia, or if it's a small fracture, I would not do this. But if it's a big fragment, then you can avoid another approach. You can just do it through the fibula, then fix the fibula, and you're fine. So just a laminar spreader to spread up the fibular fracture.
Well, thank you very much. Incredible.
review of work and a lifetime of experience that we really appreciate you sharing with us. Thank you so much. Now, we're going to move directly forward to the, we're not going to take a break. Sorry. You guys can be there.
That's trauma. It is part of the deal. Yeah, it's part of the deal. Yeah. And always come, you don't want it. Right, exactly. Thank you.